Good afternoon, everybody. Today we'll be dealing with the subject amenorrhea. Amenorrhea is literally defined as absence of menses or menstrual cycles. So, the types of amenorrhea are grossly two types: primary amenorrhea and secondary amenorrhea. The primary amenorrhea, it means never had a period. So no menses by age 16. Then we have to start investigating women for amenorrhea. No menses and no secondary sexual characters by age 14. They are also the candidate who are to be investigated. And more than 3 years between onset of secondary sexual characters and menses. Remember the telarchy, that means breast development, endarchy, and pubarchy as pubic hair development, and the menses. These are the sequelae in the women. So, the incidence of primary amenorrhea is 0.1 to 2.5% in reproductive age women. Then secondary amenorrhea has a period before, but not currently. So previously she had few periods, but since then she didn't have periods more than 6 months without a period. Then we have to investigate for secondary amenorrhea. The incidence ranges from 1 to 5%. So causes of amenorrhea are primary amenorrhea, gonadal dysgenesis. That is, the incidence is 43%. This is the most common type of amenorrhea. That is Turner syndrome. And uterovaginal agencies, the incidence is 14%, or is also called Mayer-Rokitansky Kuster-Hauser syndrome. So, MRKH syndrome. Then constitutional delay, that is about 10%. The androgen sensitivity syndrome, that is the chromosome is 46XY and Gimli, cutis, and receptor problem. In this case, also the patient gets primary amenorrhea. The secondary amenorrhea, pregnancy is the most common cause of amenorrhea. Whenever a woman becomes pregnant, she becomes amenorrheic. That is physiological amenorrhea. So then the next is menopause. This is a physiological phenomena. The average age of menopause is 51 years. So some may have earlier menopause, or some women may have late menopause. Then the PCOS, polycystic ovarian syndrome, is a chronic anovulation. Now it has become very common, and the incidence is 39%. And hypothalamic or pituitary dysfunction, the incidence is 20%. Then the premature ovarian failure prior to age of 40 years. It is very rare where the woman gets early menopause prior to 40 years. Then the other condition is anorexia nervosa, is the single most common cause of amenorrhea in teenagers. Then primary amenorrhea, quick rules to remove are here no uterus by chromosome, androgen sensitivity syndrome, or MRKH syndrome. Then estrogen is not required for development of uterus. Ovaries produce estrogen. Then coming to the primary amenorrhea, where there are secondary sexual characters are present. When they are present, uterus present. Then the other criteria, no presence of secondary sexual characters are absent, then measure follicular stimulating hormone and luteinizing hormone. If low follicular stimulating hormone, and luteinizing hormone. Then hypogonadotrophic hypogonadism is the diagnosis. When we measure the FSH and LH, there is high FSH and LH. This is hypergonadotrophic hypogonadism. Then we have to go for karyotype analysis. If the karyotype analysis is 46XY, it is Swyer syndrome. If it is 46XX, it is premature ovarian failure. And if it is 46XO, it is called Turner syndrome. So, if the presence of secondary sexual characters is there, uterus is present, so outflow obstruction is suspected. Outflow obstruction is mostly imperforated hymen or transverse vaginal septum. Here, every month the women menstruates, but the menstrual flow doesn't come out because of the imperforated hymen or transverse vaginal septum. If it's an imperforated hymen, then we have to give a cruciate incision on the bulge of the hymen. Then the woman will pass clots. So whatever is accumulated during every period, it comes out. In this case, we must do only dilatation of the cervix. No curettage has to be done. And the other outflow obstruction, there is no outflow obstruction. Evaluate as for secondary amenorrhea. Then uterus is absent, then karyotype analysis has to be done. And if it's 46XY, androgen insensitivity syndrome is the diagnosis. If it is 46XX, it is Mullerian agenesis. The primary amenorrhea, if there are no breasts, low estrogen due to dysfunctional gonads or central nervous system, check follicle stimulating hormone. High for FSH, dysfunctional gonads is the diagnosis. If low follicle stimulating hormone, dysfunctional central nervous system is the diagnosis. Then tests make anti-Mullerian hormone, which blocks the default embryonic pathway of Mullerian or uterine development. Remember that Y chromosomes encodes testis development via sex-determining region of Y chromosome. Then primary amenorrhea, breasts absent and uterus present. In the absence of breast and the presence of the uterus, think low estrogen, either no Mullerian inhibiting substance or no anti-Mullerian hormone. So uterus is present and the breast development is absent. So check an follicle stimulating hormone, high FSH, hypergonadotrophic, or low FSH, hypogonadotrophic. Check stress hypo or anorexia nervosa or hypothalamic lesion. In primary amenorrhea, if the breasts are present and the uterus is absent, think high estrogen and presence of anti-Mullerian hormone. Therefore, MRKS syndrome or here the vaginal agenesis and no uterus, that is 46XX, and caused by a random birth defect, that is sporadic, or androgen insensitivity syndrome, that is 46XY. Cells are not received to testis determining factor, that is TDF. Thus, patient has intra-abdominal testis and no uterus or vagina. Here the karyotype is 46XY. Then coming to when the breast is absent and the uterus is absent, it is very, very, very rare. Think low estrogen and Mullerian inhibitory substance is present. This is very rare. Check for karyotype. Causes include testicular regression syndrome and 7-dehydroxylase deficiency. These are the causes which cause primary amenorrhea. In other case, when the breasts are present, uterus is present, evaluate like secondary amenorrhea or think some type of obstruction like infiltrate hymen, transverse vaginal septum, or cervical agenesis. Remember, in this case, vaginal and agenesis, the uterus is absent in 90% of the time. No cyclical pain is not a, so cyclical pain is not a symptom. So coming to the etiology of amenorrhea, breast absent, uterus absent, 1720 desmolase deficiency. Breast is absent and uterus is also absent, that is 17 alpha hydroxylase deficiency, 46X5. The breast is absent and uterus is also absent, agonadism it is called. When the breast is absent, uterus is present, gonadal failure turbulence, that is 45X. And breast is absent and uterus is present, gonadal dysgenesis. When breast is absent and 17 alpha hydroxylase deficiency with karyotype of 46XX. Then with the presence of with absence of breast, hypothalamic failure is also a cause for amenorrhea. And with the absence of breast, pituitary failure too can occur. Here, in all these cases, uterus is present. Then breast is present, androgen sensitivity syndrome. Androgen insensitivity syndrome or testicular feminization. It is the breast is present and the uterus is absent. It is called AS, and uterus is present and breast is present. This hypothalamic pituitary or ovarian patient uterine etiology. Then breast is present and the uterus is absent. This is Mullerian agenesis. These are all the various causes of amenorrhea. In primary amenorrhea, MRKH syndrome, that is 46XX, and normal karyotype is 46XX, sporadic defect, not inherited. This defect is not inherited. And in these normal ovaries, they ovulate, but they produce estrogen, but there is no uterus. Associated with renal in 33% and skeletal 15% abnormalities get an IVP done. Second most frequent cause of primary amenorrhea, accounting for 15% of the cases. In primary amenorrhea, androgen insensitivity syndrome, that is 46XY, androgen testosterone receptor defect on X chromosome, either X-linked recessive or X-linked dominant. The vaginal pouch will be present, but no uterus. The Mullerian innervating factor is present. So, vaginal pouch is present, but no uterus. So, in that case, we have to do vaginal reconfiguration to make her vagina fit for intercourse. Then functioning testes are at risk for germs and tumors. Only condition where gonads are removed after puberty allow secondary sexual characters to be completed. Then coming to Turner syndrome, where follicle stimulating hormone is high, either hypergonadotrophic or hypogonadotrophic. depending on the high FSH or low FSH, caused by maternal meiotic sex chromosome non-distinction. Then not related to maternal age is 95% Turner's babies who spontaneously aborted first trimester. Then Turner's babies that survive must be genetically tested for Y chromosome material if present, gonadectomy required due to dysgermomas and gonadoblastomas. Whenever testis is present, unless we remove it, they are more likely to turn to malignants in the way of dysgermomas and gonadoblastomas. This is the case of Turner syndrome with karyotype 45XO, the most common karyotype found in spontaneous abortions. Coming to secondary amenorrhea, the most common cause of secondary amenorrhea, other than pregnancy, is chronic hypothalamic amenorrhea. Give them a progesterone challenge test to induce a period. Here, on giving progesterone challenge test, if negative pregnancy, check thyroid stimulating hormone and prolactin. If prolactin both are normal, TSH and prolactin are normal, progesterone challenge test to be given. Withdrawal bleeding occurs or may not occur. If it occurs, an ovulation. If it doesn't occur, estrogen plus progesterone challenge test has to be given. Bleeding present. If the bleeding occurs, check for FSH and LH. And FSH and LH are high, that is ovarian failure. If FSH and LH are low, that is hypogonadotrophic hypogonadism. And when we give estrogen progesterone challenge test, no bleeding, then outflow problem. Then we have to treat accordingly. Then when we do check TSH and prolactin, normal prolactin levels and abnormal TSH, thyroid disease. Then you have to treat for the thyroid disease. If normal thyroid stimulating hormone and abnormal prolactin, then prolactin less than 100 nanograms per ml, then microadenoma or other causes most likely. When the prolactin is more than 100 nanograms per ml, the MRI CT done to evaluate for prolactinemia and consider other causes if test is negative. This is how we have to investigate the amenorrhea. Then progestin challenge test is give 10 milligrams of progesterone orally for 5 to 10 days. A withdrawal bleed occurs within 10 days of progesterone challenge is positive result, and a diagnosis of anovulation may be established. If withdrawal bleeding does not occur, give Premature 1.25 milligrams daily for 21 days, then progesterone for 5 to 10 days. If bleeding occurs, inadequate estrogenization of the endometrium is the cause. Then the other causes are hypothalamic and pituitary, low or normal follicular stimulating hormone. Anorexia, most common cause of secondary amenorrhea in teenagers. Weight loss, stress, exercise, then Kalman syndrome, and anosmia, and Sheehan's, blood loss during delivery, and radiation and tumors. Patients who received depot injections may not get withdrawal bleeding for 2 years. Then coming to the ovarian dysfunction, normal follicular stimulating hormone levels may be high FSH or LH or FSH, high LH or FSH ratio. Then follicular polycystic ovarian syndrome is chronic hyperandrogenic anovulation, that is PCOS, polycystic ovarian syndrome. There is no progesterone produced to stabilize endometrium health. Thus, endometrium keeps endometrium keeps building and building, and chunks fall off every fall off. So often, LH and FSH ratio altered by higher than 2:1 only, found in part 40% of time. Consider occipitals, metformin, and clomid. These are the causes for the ovarian dysfunction. Then ovarian failure, high follicular stimulating hormone in menopause, ovarian destruction by radiation or chemotherapy, and premature ovarian failure, that is in menopause before age of 40. The incidence is 1%. Causes are unknown, autoimmune or genetic. Turner syndrome is most common cause of teenagers. Common cause in teenagers. Premature ovarian failure due to mosaicism. These patients will need hormone replacement therapy. Then coming to the chromosomal evaluation for ovarian failure. If the patient is under the age of 30, karyotype has to be done. And Y chromosome accession of gonadal area, and problem is gonadal tumor malignant, and 30% do not develop fertilization. Therefore, even normal appearing female needs karyotype to exclude Y chromosome. After age of 30, premature menopause is likely to occur. Then, cause of primary ovarian failure or hypergonadotrophic hypogonadism, it is called. Idiopathic premature ovarian failure or steroidogenic enzyme defects like cholesterol side chain cleavage and 3 beta alpha dehydrogenase and 17 hydroxylase and 17 desmolase and 17 ketoreductase. Then coming to the testicular regression syndrome, true hypoarchidism is likely to cause. Then gonadal dystosis, pure gonadal dystosis, Swyer syndrome. Here the karyotype is 46XY. Then the Turner syndrome, 45XO, and the Turner's variants can also cause primary ovarian failure. Then mixed gonadal dystosis and the ovarian resistance syndrome, Savage's syndrome, autoimmune uveitis, and post-infection. Example, after mumps, also the patient can have primary ovarian failure. Then post-oophorectomy, also vegetation of the ovary can cause this type of ovarian failure. And post-irradiation and post-chemotherapy are the other causes of primary ovarian failure. Then premature ovarian failure for women younger than 30 years, a karyotype should be ordered. Y chromosome material requires gonadectomy to prevent malignant transformation. In hyperprolactinemia, prolactin secretion is inhibited by dopamine and stimulated by thyrotropin releasing hormone. Then check for thyroid stimulating hormone. Primary hypothyroidism may cause elevated TRH, which stimulates prolactin. Then MRI or CT is recommended when prolactin levels exceed 50 nanograms per ml. MRI is superior to CT. Drugs induces hyperprolactinism or antipsychotic drugs and antidepressant drugs, prokinetics and antihypertensives, opiates like morphine and H2 antagonists and others. These will cause drug-induced hyperprolactinemia. This hyperprolactinemia, DOPA agonists, they bromocriptine block prolactin secretion and may cyclical ovulation. This is how the hyperprolactinemia occurs. Then acquired uterovaginal obstructions like Asherman syndrome, most common after years. If you curate the uterus very severely and then a syncytia may form between the uterine walls and may cause amenorrhea, that is called Asherman syndrome. And the cervical stenosis after conization or leak and pelvic radiation can also cause amenorrhea. Diagnostic evaluation by compartments, outflow tract, uterus and vagina, and ovary, anterior pituitary, central nervous system, hypothalamus, environment, and psyche. So how to evaluate? How to evaluate is by history and physical examination, psychiatric background and family history, genetic abnormalities, nutritional status, growth and development factors, and secondary sexual characters, and presence of breast, normal reproductive tract, uterus and vagina. These are to be examined, and by that, after the above said investigation, we can come to a conclusion. Initial tests for amenorrhea are progesterone challenge test and thyroid stimulating hormone. Then prolactin. TSH is elevated, hypothyroid state. Prolactin elevated, and MRI 100 nanograms per ml. Prolactin we have to see is elevated by 100 nanograms per ml. Then we have to think of amenorrhea due to the elevated prolactin. So compartment wise, anterior pituitary disorders like tumors, large bitemporal amenorrhea, and small tumors with visual defects are very rare, and craniopharyngioma, calcification X-ray may be produce blurring of vision. Acromegaly, Cushing's syndrome, and pituitary prolactin adenomas. They are micro or macro, and Sheehan syndrome. They are the various causes of amenorrhea. Compartment 4 are central nervous system disorders, hypothalamic amenorrhea. Problem is GnRH pulsatile secretion and anorexia, bulimia weight loss of in 25%, the onset 10 to 30 years. Then exercise. Thank you. So this time we have completed and covered amenorrhea. If anybody has got any doubts, they can ask questions.
ಏನು ಆಲಸ ಬರ ನೀನು ಸರ್ లేదు
వెళ్ళావు కదా క్లోజ్